First, let me welcome everyone and thank you for joining us today for this webinar. My name is Sylvette Dully. I'm a physician and I am the International Medical Affairs Director at Myriad Genetics. As you may know, Myriad is a global leading genetic testing and precision medicine company dedicated to providing better solutions to detect, guide treatment decision, and also prevent disease. So today we will focus on our discussion, on EndoPredict, a unique genomic expression test for early breast cancer, predicting individual patient risk of early and late recurrence, and also used to guide chemotherapy decisions. We will spend the upcoming 50 minutes to talk about challenges in ER-positive or HER2-negative early breast cancer, and how genomic tests can be used reliably. So to do so, we have the privilege to welcome Professor Unsch, who is the head of clinic for gynecology, gyneco-oncology, and obstetrics, and also head of breast cancer interdisciplinary cancer center department at Helios, Berlin, Germany. This is our picture. So Professor Unsch, our guest, and myself, and maybe the next one to introduce this, the agenda, a brief overview about today's agenda. So the discussion will address 3 patient cases, so premenopausal node-negative case, and also 2 postmenopausal node-negative and also node-positive cases. Each case will be followed by 2 polls. And to make this webinar a bit more interactive, we will give you the opportunity to provide your thoughts on cases using the poll questions, and Professor Unsch will comment and provide his expert opinion at the end. Just a little housekeeping before we get started. The session will be recorded, but we will preserve your privacy and making it fully anonymous. So any question you may have during this presentation, please type them in the box in your panel. Zoom control panel, sorry. And finally, just to close the presentation, we will have the Q&A session to address all these questions that you may have. And now I will step down to our guest, Professor Unsch, and let you run, Professor Unsch, the clinical cases. And thank you so much for attending.
Thank you very much, Sylvette, for your introduction. Dear colleagues, dear friends, I just counted down during the introduction of Sylvette how long I personally am involved in talking to my patients about the prognosis and what therapy or what type of therapy might be needed or is needed, because every breast cancer patient in the early setting wants to know, am I going to survive? And if not, or if not so good or not so long, what can I do to influence my prognosis? So prognostic factors are extremely important, and we look since more than 30 years for additional prognostic factors aside with the usual ones which we know, which is tumor size, axillary lymph node status, grading, ER, PR, HER2 receptors, Ki67. And obviously, multi-gene assays are in place to be used. And I think today there is quite a challenge to discuss together with you about all the clinical practice. And these are cases which we see every week, almost every day. And it makes sense to share your experience, our experience, the knowledge from literature, and the experience with this test. So we have chosen, absolutely like it happens in all day clinical life, 1 premenopausal patients with node-negative disease, 1 postmenopausal patients with node-negative disease, and 1 postmenopausal patients with node-positive disease. And obviously, there is a polling. Please ask your questions. We have some time at the end to discuss the cases and also to hear your opinion. So let's start with case number 1, premenopausal woman and 0. She's a 43-year-old premenopausal woman. She's a teacher, and she had the following clinical features. In November 22, right side breast cancer, no special type, lumpectomy with sentinel node, tumor diameter was 19 millimeters. None of the 3 sentinel nodes removed was involved with tumor cells, no lymphovascular invasion, and the grading was 2. ER and PR highly positive, HER2 negative, and the Ki67 is 15%, which at least in many of our centers is routinely done, and that value of 15% is kind of at the edge between luminal A and luminal B. You might know since many, many years, we try to define, or additionally, not just by the genomic, but also by the clinical and pathologic features, what luminal B and luminal B, A and luminal B is. So Ki67 is kind of at the border. She had breast surgery. She had adjuvant radiation of the right breast with a boost of more than 50 grays. So in this very common case, what would be your decision for systemic treatment considering this clinical scenario? So is it chemotherapy followed by endocrine therapy, the more or less the more aggressive approach? Is it ovarian function suppression plus endocrine therapy, so which is endocrine therapy for premenopausal patients? Is it endocrine therapy alone, which in that case might be either ovarian function suppression or tamoxifen, because obviously aromatase inhibitor in a premenopausal patient is not a good approach. Maybe you're not sure, you need additional information. And the next one is that, this is a case in which you or I would request a gene expression signature to get more clarity on the risk and the treatment decision. So please decide between chemo, ovarian function suppression, endocrine, which is the maximum endocrine therapy alone, which might be mostly tamoxifen, not sure, or you need an additional gene expression profile. Please. I wait for your signal and then we will discuss the further follow-up here. That's good. I like it. I mean, this is perfect. So most of you, which in Germany at least is enough to build the Bundestag, because 56%, the majority, also request a gene expression. Some of you are not sure, which is perfectly fine. So this is why we are here today. And let's see what the following is. And I have to go back to the slide. So again, 43-year-old, so premenopausal, 90 millimeter breast cancer, node negative, G2, ERPR positive, HER2 negative, Ki67. So this patient received an oh, excuse me, I did something wrong. I have to go back. Can you see it again? Yeah. So yeah. The EndoPredict of this patient is low risk, which means that the patient has an exact calculation. And this is what I like about EndoPredict, because I liked it from the very beginning. It gives us a very clear number with which we can talk to our patients. So the likelihood of distant recurrence within years 0 to 10 is 8%. Absolute chemotherapy benefit at 10 years is 2%. And likelihood of late distance recurrence within years 5 to 15, because that is the time point at which usually we stop endocrine therapy, is 6%. So this is always provided that we give the patient an adequate endocrine therapy, which mostly I think is tamoxifen. For some of us, including me, I would even go for ovarian suppression, function suppression, and either tamoxifen or aromatase inhibitor. And this is all covered by the guidelines. So I think this is quite an important point to make here, because now we have very clear numbers. And the next one is, so now you have the result. And therefore, again, the question, what is your choice in this patient? What would you advise? Is it chemo followed by endocrine, Is it ovarian function suppression and endocrine, or is it endocrine alone? Which endocrine alone mostly is tamoxifen. Please vote now. This is an extremely nicely splitted vote because this is what I see all over the places. So yes, the majority is endocrine alone, which is I can perfectly live. Now, for those of you who decided for ovarian function suppression with endocrine, I think you are in a very good company, together with me at least. So in this case, I am in a minority, but we are all agreeing that chemotherapy is not needed in this patient. Now, the data which are coming from most of our studies with multi-gene assays are from the era in which in premenopausal patients, mostly chemotherapy was done, and if endocrine therapy was done, it was mostly tamoxifen. Now, you have seen that this patient has quite a risk of late recurrence. And I think, this is what I think, and we have some data from text and soft, which we're not doing a multi-gene assay, to tell such a patient, if she's asking us, what can I do to reduce that slightly increased risk for late recurrence? And I think what we can tell the patient is, okay, then we can go for the full endocrine combination, which is ovarian function suppression with endocrine therapy. But again, this is something we can discuss at the end. So perfect. I like very much this result. And I think this is, up until now, a very nice closure. This is not a final closure, the closure of this case. Okay, now let's go to the next one. Yeah, so the systemic therapy for this patient, as you see, she decided to go for tamoxifen since January of 23. I talked to her about side effects. Obviously, if you combine it with ovarian function suppression, she will have more side effects. So tamoxifen is something which these patients are dealing with quite, not easily, but they cope quite well with the side effects. Okay, now, supporting data, because that was always for all multi-gene assay. When we started to do multi-gene assay, we did it mostly in postmenopausal patients. So in premenopausal patients, there were increasing knowledge from different studies, as you can see here. And this is a quite recent one from Dr. Constantinidou from the Clinical Cancer Research this year. And what you very simply see here, at the 10 years median follow-up, those who have an EP clean low risk are doing excellent. And those who are having an EP clean high risk have 24% distant recurrences. So distant recurrences is something of which patient can and probably will die. Even after metastatic disease, there is quite a few of therapeutic options. So the most important message for the patient here is, even in premenopausal patients, we have an excellent knowledge, we have data, and we also can recommend the EndoPredict because it's an excellent factor or an additional tool to really assess the risk of the patient. And with a risk of 24%, obviously, the patient is asking us what to do. So in those patients who are at low risk, the majority in this case, we can tell them, well, your risk is less than 5 or less than 4% at 10 years, that's fine. And for those other patients, obviously, the major question is what to do, being it either chemotherapy, being it either prolonged ovarian function or prolonged endocrine treatment, or the combination with ovarian function suppression. So postmenopausal woman, N0, 68-year-old woman. She's a retired lawyer. Clinical features: in December 21, she had right side breast cancer, no special type, lumpectomy with sentinel, 9 millimeter tumor, no involved lymph nodes, lymph node negative, G2, ER/PR 100% and PR 50%, HER2 negative, and the Ki67 is 40%. She had breast surgery. She had radiotherapy to the right breast. So what will be your decision when this retired lawyer is coming to your office and asking you chemotherapy followed by endocrine therapy alone, not sure, or you need a gene expression? Okay, please vote now. And the result is you need a multi-gene expression assay. Perfect. So let's go for the multi-gene assay. Okay, now the patient has an EP clin risk score of 4.1, which is by definition high risk. The likelihood of distant recurrence within years 0 to 10 is 19%. The absolute chemotherapy benefit at 10 years is 8%. And the likelihood of late distance recurrence within the years 5 to 15, so after 5 years of endocrine treatment, is 15%. And obviously, with this in hand, I think, and it doesn't have to be a retired lawyer for every patient, we can explain it quite good, what the individual risk is, what the absolute benefit is, obviously the side effects, and then how to make patient the decision much easier. Clinical information for an EP clean risk of 4.1. On the left side, the 10-year likelihood of distance recurrence. Now, this is what is of most interest for the patient. Obviously, the local regional recurrence is also important, but the patient wants to know, if I'm going to have metastasis, then I know that I'm going to die of cancer. So please tell me what my risk is. So 10-year likelihood of distant recurrence, as you see here. So this is something which is very, very reassuring, that the EndoPredict clinical risk is something which is a linear factor, is a linear argument to talk to the patient. And you don't have to finish medical school to understand this line, because obviously you see, if you are below that threshold, then having a risk score of 3.2 or something, then you're fine, you're okay. And the higher the risk is, the higher the risk of metastasis is. And obviously from there also the therapeutic decision is going to be made with an absolute chemotherapy benefit at 10 years, which is, again, the higher the risk, the better the increases, which is telling us something about the predictive benefit of this test, and also the likelihood of late recurrences, which is also very important piece of information, because you can imagine, if this patient comes to us and she's 60-something years old, and she has a life expectancy of at least, let's say, 25, 30 years, then she knows, I don't want to know just my short-term follow-up prognosis. I want to know, how am I going to do for the next 15, 20 years? And this is a very important piece of information. And the next one. Okay, so please decide what would be now your treatment decision, considering what you have just seen. Is it chemotherapy followed by endocrine therapy, or is it endocrine therapy alone? Please vote now. For those of you who voted 3 out of 24, endocrine therapy alone, I am sure you must have many reasons, which maybe we can discuss at the end of this presentation. But it's quite good splitting. But again, the majority, absolute majority, is for talking to the patient about chemotherapy. Okay, so systemic therapy was decided with the patient, not just for the patient. Adjuvant chemo with 4 times CC and 12 paclitaxel. We can also give, I talked to the patient also, we can also give an anthracycline-free regimen. And obviously, because she also had in her mind that there is some additional risk after year 5 to go for a aromatase inhibitor, and probably even to go for a longer treatment and just do not stop at 5 years. Okay, now at least for the follow-up until now, she's doing fine. in postmenopausal patients, now this is a quite large database. You see here thousands of patients from ABCSG 6 and 8, from Philippides, and also from Dr. Booth, and on the right side from the TransAttack study. Again, same story again, majority, low risk, long-term, just a few patients with metastasis, and those patients who have EndoPredict high risk have higher risk of metastasis, and also in those patients from the TransAttack study with 20% risk of metastasis. And again, it's a minority, but it's important to define and detect this minority, less than 30% of the patients, in order to tell them what to do. So this patient here, she was from the so-called minority, but the multi-gene assay is helping us to talk to the patient, to give exact numbers, and not just, oh, I have the opinion of doing this and I have the opinion of doing that. Because especially this lawyer, she said, oh, I want to see the clear numbers. If you give me the clear numbers, then I will make a clear decision. So again, this is quite a very nice piece of information. And again, from the curve you see here with a 10-year risk of distant recurrence, and again, it's a linear increase of the risk with the increasing risk in the EpiClin. So this is again reassuring that the higher the risk, the higher the benefit from chemotherapy. Obviously, a very low risk or a low risk patient do not have any benefit from chemotherapy, just the side effects. And that is again something really extremely important about multi-gene assay. Patient number 3, postmenopausal with N positive. Now, I have the impression that we did quite a good job in node-negative breast cancer patients, and then obviously the patients who have maybe 1 or 2 involved lymph nodes are coming to us and telling, well, yeah, but my neighbor in my room had a multi-gene assay, she's doing fine, and you told her that she has a multi-gene assay which is negative or low risk, and she's not receiving chemotherapy. Now, most people are telling me, oh, I have to do automatically, I have to do chemotherapy because I'm node positive. So what about also including the node positive breast cancer patients? Obviously not those with more than 4 lymph nodes, but those who have 1 or 2, or maybe at maximum 3 lymph nodes involved. So 50-year-old postmenopausal woman, again, she's a number fan because she's an IT specialist. She has the following clinical features. Detected in February 2021 with right-side lobular breast cancer, breast conserving surgery with Sentinel. She had a multifocal tumor, PT2, 2 out of 8 lymph nodes involved. She's hormone receptor positive, HER2 negative, Ki67 is 10%. So the little therapy was breast surgery, adjuvant radiation, chest wall and regional nodes with 50 grays. And well, again, node positive, quite a larger tumor. So the question is chemotherapy followed by endocrine therapy. Can we do endocrine therapy alone? Is it good enough? You are not sure, or you also need a gene expression profile to make your therapeutic decision. Please vote now. Okay, so majority still need a gene expression signature, almost 80%. So let's go for the gene expression signature. And here it is. So again, 50-year-old patient, IT specialist, multifocal tumor, PT2, 2 out of 8 lymph nodes involved, hormone receptor positive, HER2 negative, Ki67, 10%. She had an EndoPredict result with 3.2, which by definition is low risk. The likelihood of distant recurrence within 10 years, 9%. The absolute chemotherapy benefit at 10 years, 3%. The likelihood of late distant recurrence within years 5 to 15, 7%. So again, I think with this in hand, especially for this patient who is a fan of numbers, she's an IT specialist, she dealt quite good because she knows what the numbers are talking about. Because patients do not like a relative risk reduction or relative risks, they want to know the absolute one. So these are the numbers. Again, by definition from the lymph nodes, she would have probably she would have received chemo. With these numbers here, maybe you can decide. And the next one is the next polling, and which is having this information in hands. Is it chemo followed by endocrine? Is it endocrine alone? Please vote now. Such a pity, not such a pity, but in the times when we did not have this kind of multi-gene assay, most of us, or many of us, would have opted for chemotherapy. So we can say in this patient, we skipped chemotherapy, and the patient was quite happy. And therefore, we have one more, and one more we need is this one here. So the patient went for aromatase inhibitor. At this time, she has no evidence of disease, and most probably or possibly she will decide to have a somewhat longer treatment of endocrine therapy than just quote by quote 5 years. Let us see what the data are in postmenopausal women node positive. And these data are coming again from Dr. Philippis in the Journal of National Cancer Institute published. ABCSG 6 and 8, about 1/3 low risk. These patients are doing excellent at the 10-year follow-up with less than 5% distant metastasis, and 24% of them who had EP-clean high risk had metastasis, and very similar numbers from the TransAttack study showing us that these patients, again, about 20% being low risk with 5% long-term risk of late recurrences or late metastasis, and 40% of metastasis in the EP-clean high risk. Excellent, excellent tool in our hands to really tell our patients what their individual risk is and what we might do. So when I introduced the EP-clean in my clinic many years ago, I was asked by most of my attending doctors, my residents, my dear colleagues in pathology, okay, now tell us something more. Tell us more. How can you convince us so that we convince our patients? And I said, okay, let's start with the following. Number one, what is the scientific basis? It's a second generation test. So it's not a Volkswagen Käfer, you know, the little one, which is very fine. It's the next generation. So like, you know, the one, maybe it's already a hybrid, okay? So it's trained and validated in hormone receptor positive, HER2 negative, node negative, and node positive 1 to 3, pre and postmenopausal women. So very tough and solid scientific data. It combines tumor gene expression and key clinical pathological prognostic factors. This is what other multi-gene assays did not for many years. And this is something very, 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 clinically important, because obviously we, the clinicians, used to deal with tumor size, grading, hormone receptors, HER2 status, number of involved lymph nodes or node negativity, lymphovascular invasion, Ki67. But this is in addition to the clinical features and the pathologic features. We have consistent results from 5 clinical studies with level 1 of evidence 1. We have prospective evidence confirmation of clinical validation studies. We have excellent data on prognostic value, and by seeing those linear curves, you have seen that also the higher the risk, the worse the prognosis, the better the prediction of therapy was. So that is also something which is involving the predictive role of this test. So we know how to tell our patients and that is really, really very nice about the test, the absolute benefit of a chemotherapy, because this is what the patient wants to hear from us. She doesn't want to hear, oh, we have to go for chemo, or to tell her, no, we don't need chemo. And then at the end, she might have an EndoPredict, which tells us that the absolute risk, the absolute benefit from chemotherapy might be 8%, because with that number, she can deal much, much better. And we have an excellent performance in node negative and node positive, as well as the pre and postmenopausal patient. So premenopausal patient, also, we have very large evidence. Very important. The tissue doesn't have to be sent over the ocean. It's something we can do in many of our labs. So like, for instance, I do not know the numbers at the moment, but in Germany, we had for many years, like, I don't know, 15, 16 laboratories doing this test. So we know they are doing an excellent job. It's not like with grading. With grading, you give the same tumor to 20 pathologists, you give 20 tumors to 20 pathologists, and then the congruence of G1, G2, G3 is not 100%. Sometimes is worse than 50% overlapping, which is a problem. Very nice. For people which are simple-minded like me, binary classification for individual low, high risk is perfect, because then I can tell my patient, you have high risk, we can do this. You have low risk, we don't have to do this. We have one cutoff for all patient groups. And last but not least, we also have clinical data additional. And Sylvette, if you allow me, I will also share these data with my dear colleagues, because that was something which I always used in my with my colleagues when I was doing teaching lectures, to show them what is it about. And this is very nice, coming from the presentation of Dr. Klein from the Tumor Center in München, San Antonio 2022. These are real-world data. So tumor-related disease, distant metastasis-free survival by EpiClean low risk, by EpiClean risk class. So you see the low risk, the patients were doing excellent. The high risk, again, this patient had quite a high risk of recurrence. The same also in premenopausal patients, 122. 63% of them were low risk, and they were doing excellent. And those less than about 30%, they had a high risk of distant recurrences. So the EndoPredict can identify patients who may avoid chemotherapy regardless of the menopausal status. This is a major message here. Data from the Berlin registry, 5-year prospective data, EpiClean low-risk endocrine therapy alone. We can tell the patient, this is reassuring, 5-year, no risk, almost less than 3% risk of metastasis. Excellent. EpiClean high risk with and without chemotherapy. Again, this is not prospective randomized, it's just as the patients were treated. And you see those patients who did not have adjuvant chemotherapy, they are doing worse. So again, this is something reassuring that with increasing risk, we can also tell the patient that they have also to do an additional therapy. Now, one of the simplest questions I ever had with my colleagues and my patients is, yeah, but I have a grade 1 tumor, and having a grade 1 tumor, I'm not high risk. Okay, the majority is true, but we see a very small minority of the patients, very small, well, quite small, 22%. They have a high risk. So again, even in G1, we can have a small group of high risk. In G2, now this is the very nice area of multi-gene assay, because we can nicely delineate between high risk and low risk in grade 2. Now for low risk patient, for grade 3 patient, in which usually we were saying, oh, grade 3, she needs chemotherapy. Always, this patient needs chemotherapy. Not many from this group here, those 13 patients who had grade 3, but had an EpiClean low risk. Again, 1/5 of this patient population, G3, excellent outcome with EndoPredict, because EndoPredict in these patients said, you are low risk. So this is something which I very much like. This is something I show my patients, and then they come and say, oh, I don't go, I'm not going to have a second opinion. You convince me, okay? And last but not least, Ki-67. Now, I love Ki-67. Ki-67 is an old test which was introduced, imagine, in 1986. Now, it was forgotten for a long time, and then was reintroduced, and most of us are using it. We in Germany love it. It's fine, it's an additional one, but this one, again, cannot tell us, okay, Ki-67, low, luminal A, perfect, no chemotherapy, is not true. 29% of these patients are still high risk. On the other hand, those patients with luminal B, Ki-67 high, 1/3 are low risk by EndoPredict definition. Also something which I like to show my patients, and they don't need university to finish university to understand this, the curve. And the classification of Ki-67 high and low, again, often is often, seldom is seldom. Yes, the high risk epiclin is in the Ki-67 high, but we still can have those patients, 90%, who are clinical high risk in the lower epiclin low, and on the other hand, 1/3 of those patients who are Ki-67 high but have an epiclin low risk. So again, this is something which is reassuring for the patient. This is very important when we talk to our patients, and the discordant classification is showing us Ki-67 is very good to have. It's very good to have, but again, EndoPredict, in addition, can tell us much better what the classification of the patient are and what the estimation of prognosis is. And we finished exactly 15 minutes before 5 p.m. and now we are open for the Q&A session. Thank you so much. And we have 58 people online. Fantastic.
So thank you so much, Professor Wunsch, for your great talk and for the supporting the right time. So we will maybe go ahead and take some questions from the audience. And by the way, you can type your question in the Zoom control panel if you want at time. We have some question. One of these questions is, in your daily practice, for which patient profile do you run an EndoPredict test or a genomic signature? So of course we are speaking about EndoPredict. And what is your experience with EndoPredict in your routine practice?
So in which patient I'm using it?
Yeah, which patient profile?
Well, I started in the beginning. I started with postmenopausal patients. Then I extended it to premenopausal patients. So virtually, I would not say in 100%, but in at least 60% plus node negative, I use the EndoPredict, number one. Number two, in patients with 1 to 2 lymph nodes, I personally am a little bit conservative with patients who have three positive nodes. If they are postmenopausal and have, let's say, low risk histopathologic and clinical features and have 3 lymph nodes involved postmenopausal, I still do an EndoPredict because I still see patients with a low risk EndoPredict. And what is very important for my patients and for me personally is that in the premenopausal patients with 1 to 2 lymph nodes, EndoPredict is a standard, and this is something which I think is quite important, because in premenopausal patients, we still know there is a chemotherapy benefit. Some of this chemotherapy benefit is coming from the ovarian function suppression or by the effect of the chemotherapy on the ovaries, and therefore we have to know the information about prognosis and how to counsel our patients. So I do not make any difference whether I use it in G1 or G3 tumors. In G2 tumors, it helps us a lot because the G2 is most of the patient, and this is leaving us with a lot of uncertainty what to tell to the patients. And again, roughly, 67, 2/3 of our patients are receiving the multi-gene assay, and even quite a majority of those with 1 to 2 lymph nodes, and for instances also in 3 involved lymph nodes in the postmenopausal.
Okay, thank you. That's perfect. So a question from the audience. So could you share the prospective level of 1A of evidence supporting EndoPredict?
If I can what?
Support the prospective level 1 evidence supporting EndoPredict regarding the studies.
You know, I know the whole story about prospective and retrospective discussion, which we're having since more than 20 years. And quite a large amount of information first was coming from validation from the first studies and then from validation studies. But today, if we would like to do a prospective randomized trial, like for instance, in patients who have an EndoPredict high risk to be randomized between chemoendocrine versus endocrine alone, that would be unethical, because I have already the information which I need. And therefore, this is level 1 evidence for the prognostic value. In terms of chemotherapy benefit, this is a discussion which I like really to make it, to answer in a very differentiated way, because patients who have, or in the past, let's say 15 years, patients who had their therapeutic decision, chemo yes or no, according to the EndoPredict test, was not done. We have level 1 evidence from retrospective data in postmenopausal patients, in premenopausal patients. We have also from the Spanish group very good data in patients who receive chemotherapy, and still the premenopausal ones have a very high prognostic impact of EndoPredict. But again, it would be unethical to do a new study in which we would prove the level 1, 1A, 1A plus, whatever, of the predictive validity, because predictive validity is telling something the patient, like, you have this risk and you have this benefit from chemotherapy, and you have this risk and you have this benefit from chemotherapy. So therefore, I know this is a critical question. It is something we have to openly discuss with our patients and the colleagues, but the piece of evidence at the moment is very good, very good.
Yes, maybe if you allow me to maybe add something regarding our clinical validation study and the level 1 evidence, we have that according to Simon criteria, because we have 6 validation studies from postmenopausal to premenopausal women, and with this randomized control trial, which were run so many years before, and when we run a retrospective or EndoPredict test, and which is perfectly in, I would say, according to Simon criteria, filling the criteria to allow this level 1B of evidence of EndoPredict. And secondly, we have this UNIRAD study, which is of course dedicated to another population, but which was run in a clear level 1A of evidence, and supporting also the fact that when we are able to find the EndoPredict low-risk patient, whatever are, I would say, the population, when you're EP low risk from the beginning, you remain epically in low risk with the follow-up we have. With the limitation of UNIRAD, because of the follow-up, it's a bit less than 5 years, but the clinical population was very high risk type.
Yeah, absolutely.
A second question that we have is that, again, in your practice, what is the rate of treatment decision change according to the EndoPredict results in your practice?
Can you repeat the question, please?
Regarding your practice, what is the rate of clinical change, clinical treatment change decision according to the EndoPredict test results?
The rate of what? To change the treatment decision?
Exactly.
1/3. 1/3.
Okay.
Yeah.
And within the population, and also So how many, again, how much regarding premenopausal and postmenopausal
Oh yeah,
cases?
that's different. In in postmenopausal patient is 1/3. In premenopausal patient, even higher. It's about 40%.
Okay.
So treatment decision change. So clinical feature, histopathologic feature, and then plus or minus EndoPredict, because this is what an exercise I was doing for many years with my residents and my attending doctors. I was telling them, what would be your decision now without having the EndoPredict? I had already the result. And they were saying this or this or this. And I said, okay, here's the EndoPredict. And then treatment decision. And also, what I really like to repeatedly say and state, the treatment decision is done by the patient, is not done by us. We just have to talk to the patient, and the patient, if the patient has enough information, she then can decide, and this is quite important.
Definitely. I have another question from the audience, which is a good question as well, according to the actuality in breast cancer, is regarding what about the HER2 low population? So of course we don't have the data at the moment, but this is a population which is included in our data.
Okay, now this is this I think HER2 low is the best marketing idea in the last 20 years in breast cancer. I'm not going to deal with the topic of HER2 low because it does not play any role in early breast cancer, period. HER2 low is something, okay, let's do it. Let's maybe have two statements to this. The data in the Destiny-04 trial, in which France was the best recruiting country in the world, are very convincing because we're talking about a metastatic breast cancer population in which an antibody drug conjugate was used, T-DXd, period. Since we knew from the drug, from the preclinical model, that it works in HER2 low, obviously it was quite nice to see that it works also in patients. But what the antibody is not an antibody. Is a chemo. Okay, now in early breast cancer, we have published some data. We have published some data from the German group, Carsten Denker, our pathologist. And yes, it is something we have to keep the eyes on, but from the scientific point of view. From the prognostic point of view, at the moment you decide, at the moment you have a patient in front of you who is HER2 low, which is HER2 low by definition is 2+ with FISH negative or 1+, period. So quite a large amount of patients HER2 hormone receptor positive are HER2 low, but it plays no role in the therapeutic decision in early breast cancer, period. Okay, so let's look forward what will happen with this marker, marketing marker, and then we can talk again about it.
Perfect, thank you. And another question regarding, from your perspective, what would be the, I would say, the target Ki-67 to ask about a genomic signature?
I love the question. I love the question. Is it coming from you or from the chat?
From us.
Okay, good. To be very honest, in the first years, I did not ask for an EndoPredict in patients who had a Ki-67 lower than 10%, period. Number one. Number two, in patients with a Ki-67 higher than 30%, I was asking, but just to be sure that it is giving me the reassurance that these patients are high risk, which is not true. And in patients with a Ki-67 less than 10%, it's also not true. So yes, the majority of Ki-67 less than 10% are EndoPredict low risk, period. But if I find one single patient, it's more than one single patient, in a patient population of Ki-67 of less than 10% Ki-67, who is EndoPredict high risk, that single patient might be very important to be counseled what to do. And on the other hand, those patients where Ki67 higher than 30%, or higher than 40%, which by definition are luminal B, I still find EndoPredict low patients, and those patients I can tell they are doing fine. So this is the major advantage of such an exact test like EndoPredict.
That's clear, definitely. So any other question from the audience?
We are on time.
Definitely, you're absolutely perfect. 2 minutes before the gong. So if there are no additional question.
We have still 53 people online, which is fine.
Exactly. So I think if no other question from the audience, maybe I would like to thank everybody, and first our guest, Professor Uchen, thank you so much for your availability, for your, I would say, the clarity of your explanation and supporting us to run this webinar. And thanks again to my colleagues, so from Ozan, marketing, Catherine, and Sebastian, and all the distributors who participated to run this project. And thank you so much. I wish you a good end of afternoon and a good long weekend for some of you who are off for this long weekend. And thank you so much. See you soon.
And I will say, auf Wiedersehen, au revoir. In Romanian is la revedere. Thank you so much.
Thank you so much, everybody, again, for your support. Bye-bye.
Bye-bye.